Welcome to Below Her Surface. I'm Lily Cook, founder of Metaphysical Wellness. In a world full of quick fixes, this is a space for depth. From hormones to mindset to biology, we ask, what is really going on beneath the symptoms, the labels, and the trends? This show is for anyone seeking a more human, honest, and science-literate approach to health. Let's go there, below the surface. Hello, Adrian. Welcome. So today we are going below the surface with Adrian Adams, who is a clinical nutritionist and naturopath, specializing in, I asked this to you, specializing in, to be honest, everything, but integrative medicine, the gut, and then also hormonal health, body composition for both men and women. So thank you for coming. I'm so excited for us to chat and to get into it. So Adrian's been pretty pivotal in my journey and my health. I feel like I've known you for a very long time.
Since 2020, I'm pretty sure, 2019.
Yeah, so for a very long time. Adrian was actually my lecturer at uni. Yeah. So a lot of what I know and how I practice, I definitely owe to you. And I want to get into a little bit of that and sort of why I think we study the way that we are and like that we practice the way that we do in that sort of sense. But now we work as colleagues, clinicians, and just bounce around ideas. So I'm really, really excited to have him here. I believe that you are really authentic in the health and wellness place because it's not just your workplace, I would say. It's like definitely your passion, and it's always something that you've got like the next idea or something that you're excited to do. And I would say that you're an encyclopedia of knowledge when it comes to just the next thing. So where would you say that your passion for health and wellness came from?
It probably started when I was much younger. So like I just like sports. I liked how my body could perform and win something. So from that, I think like my earliest memory of looking into that was trying to win races and athletics kind of carnivals at school. I had my mother as a little bit of an idol there because she did really well in racing. So I was like, oh, I want to be like my mom. And my dad was also very physical in terms of when he was younger too. So I had kind of like good role models there. But it was, actually this one's kind of a funny side note, but people may remember Danon's Direct, the kind of like TV channel that sold you loads of exercise equipment, the latest ab machine or the latest kind of
back
thing.
In that time.
Yeah, back in the day. Obviously this all goes online now. But yeah, I'd watch these channels. Oh, cool, those people are doing kind of training to help them do better in sport or to improve their health. And my dad got one of the machines, of course, and I'd use it in secret when he was at work.
Was it one of those ab machines?
No. So what it was kind of it had like elastic bands in there. You rest it against the wall. It would turn into kind of a chest press machine.
That's right. I remember those.
Yeah. So I do that, and then I'd find hills and go sprint up them and this sort of stuff so that I do better in my 800-meter race that I had in year 7, as an example.
Yeah.
I think from there, it just lit a spark, and I really like this. I really like how I can make informed choices and then see the outcome. Yeah. Then I had my first kind of like health challenge when I was about 16. So I developed cystic acne. I had a little bit of it, as a lot of teenagers would do, but then all of a sudden something kind of like flipped when I was 16 and it became kind of really severe. And that's where like that affected my self-confidence. It really upset me as a 16-year-old. And I went to my first specialist. So we went to a dermatologist, my mum and I, and the options weren't very good. My mum was quite patronized in that appointment in terms of the choices, and you should make this choice for your son.
Can I ask what the choices were?
Yeah, so it was Roaccutane and steroids.
Yeah.
Yeah, so which is, we know this is a pretty standard therapy for cystic acne. There was no other talk of any other lifestyle, dietary related, whether you were getting sun exposure, what happened in the past, why did it get triggered? All the questions that we ask as clinicians, none of that. It was just like, oh, you got cystic acne, this is your treatment. Yeah. You're going to have all these side effects. You're going to have increased depression risks, suicidation risks. You're going to have liver enzymes elevated. You're going to do this. And obviously that freaked out my mother and went, that's it. we're going to go find a different option.
Especially when you're 16 as well. It's like you're so young and that's the only therapy.
Yeah, well, that was my only,
Yeah.
inside of what the kind of next level of the medical system was like. So I actually thought the tests were kind of cool. So I was like, oh, yeah, cool. Get to all these tests, right? I still think they're cool.
Yeah.
So I did those. And then this is when I visited my first naturopath. So shout out to Deborah Taylor. I ended up actually working for her 10 years later.
Mm.
And she went through all of the stuff that I now know. So what are you eating? How are you sleeping? What's your stress levels like? What are you applying to your skin? What happened around the time it started to get worse? And have a look at the deficiencies associated with that condition. And then we started treatment. And within 6 to probably 9 months, like the cystic part of it was resolving. Yeah. And that's where I went, my interest in human biology per se that came originally from sports and my own performance, that all lit another spark to go, oh, cool, this is a really useful body of evidence and traditional medicine that I can use and maybe do a career. I didn't think about that at age 16. I thought I was going to be a PT or actually a dietitian, and I didn't really know about this area of medicine. But from those interest bases there, it was my start. So as soon as I finished high school, I was straight into summer school.
Right. Summer school being in terms of
so basically in the college system, you can study all year round.
Right.
So I didn't need to wait for university to start after year 12.
Yeah.
I went straight into studying nutrition.
And back then, was it just a diploma?
Advanced diploma.
Yeah.
Yeah.
Okay.
And then it was, you got your advanced diploma and then you could finish off your university degree at nominated universities around Australia.
Right. Okay. And so getting into that, finding this, I feel like it's still such a gap in the market and there's still this fight between, conventional medicine, alternative medicine. So seeing that real differentiation, I guess, in that, what from there made you go, okay, now I want to get into integrative medicine where I want to, and if someone doesn't know what that is, can we explain that? I want to combine doing blood work, doing that kind of assessment, and then utilize both sort of forms in order to treat someone.
Yeah. So in the kind of college system around naturopathy, nutritional medicine, and other forms of traditional medicine like massage and things like that, essentially we were against medicine, so to speak. You had a lot of those personalities.
That's what it felt like, yeah.
So it was like, don't take medicine, take traditional medicine because you don't want to poison yourself with this stuff, right? And I don't blame them. A lot of people that I was studying with were burned by medicine in terms of maybe a side effect or a horrible experience. So I don't blame them for that kind of point of view. But it eventually doesn't make sense when you're like, I'm really just after an outcome in a patient. Or if I'm looking at me personally, I just want to feel better. I want to perform my best, what I call the kind of genetic potential of an individual. And as long as something's safe and or there's a minimal side effect, and remember there's always a potential side effect with a herb or a nutrient potentially. Most of the time the side effect profile is really low. There still is a risk. As long as I've got that right balance, I don't really care what I'm recommending. Yeah. It's safe and effective is what I tell my patients. So that once you have that mindset, then integrative medicine makes complete sense because you're looking at, I'm going to grab the best of every world because my only concern in the clinical setting is the outcomes of my patient.
In what sort of circumstances would you consider both conventional medicine and alternative medicine? So where would you kind of work with a doctor, with a patient in that kind of realm? Can you get into that a little bit?
I probably really honed this skill when I started to work within a clinic with GPs. Yeah. So this is where I moved to Invitation to Health on the Central Coast. And I started to work under some really experienced integrative GPs. So Dr. Penny Caldecott, she's a GP that kind of pioneered this joint system of like going, well, I'm not a naturopath, speaking in terms of her, and they have all these skill sets. Why do I need to learn those when I've got the skill set, it's useful? Why don't we combine the two clinicians together? So we started, or she did, and then I come along in 2020 and went, oh, this model's great. Can I get involved with it? And she terms it the deep health model, but essentially it's where you've got an integrative GP and a naturopath. And concerning me, I'm also a nutritionist, working in the same appointment. So we've got that patient there, and we've got two professionals with different skill sets, analyzing what's going on for this patient, what's going to be the best approach. And it's a game changer in terms of results. Like the patients love it because essentially they feel supported. Also, you can get some of these people over the line that have been burned by kind of conventional medicine because they're not getting the right checks because they're like, I don't want to see the GP anymore. Where I'm like, actually, they're very valuable. We should have them involved in your medical care team. And we rebuild that trust with obviously the right professional.
Yeah. And I think that's what people often don't understand with well, in Australia, we can say, but I'll get those questions a lot where it's like they've been burned by conventional medicine, but then there's also this element to conventional medicine where there's a legality issue there, right? So GPs legally can only sort of prescribe in a certain way or can sort of speak on topics, or even if you send for a blood test that they're not familiar with, they definitely won't comment on it. And as someone that's a client, you could take that as, okay, they don't care or they're not really investigating into my health, but it often isn't that case either. It's just being really careful. Now, that was like sort of an aha moment for me and something that you said to me when I was studying nutrition, because I always felt like previous to sort of understanding how you could combine the two, I always felt like, okay, I'm going to have to study medicine in order to practice in the way that I would like. And I remember speaking to you and saying like, because here you have to do the GAMSAT and you have to sit that, and it's a whole journey to be a doctor on top of studying a bachelor or a degree before that. And then I remember you saying to me, look, in the way that you were speaking about yourself, you're like, the way I want to practice and essentially how I want to practice too is you are very limited. So for example, you can't prescribe zinc at a therapeutic dose because you have to, have all of that written down. And that was like quite a good moment for me moving into how we can practice and how I feel like you can really help people in a way that you wouldn't with conventional medicine. Can you speak about that sort of when you were getting into, you were saying that you were going through that same journey and you were going into study medicine and then why you made that different decision to go in this way?
Yeah, so I had kind of like two additional pathways that I wanted to do. So I wanted to get into naturopathy, nutrition, and gather those skills. And then I was looking at what am I going to do as my post-grad. And I either had go further down in the nutrition path, so become a dietitian and then become an allied health professional, or go into medicine, become a general practitioner. So, the reason I decided not to was there's a lot, let's say if I concentrated on being a GP or medicine, there's a lot of things that I didn't want to do and I'd have to go through all of that training. Yeah. So
what sort of things?
I don't really want to excise someone's ulcer or a wound and stuff like that. So
it's not for me.
It's not for me. I could have gritted my teeth and got through that process and then never did it again. But it is involved with, a GP. They are very hands-on in health. So they are looking at, wound care and these sorts of things, generally in combination with a nurse. So that wasn't my cup of tea. And the other thing is they are quite highly regulated. In part, they should be, and in other part, I think it's overdone.
Yeah.
With the education I had a lot of freedom. If we have evidence, we have safety, I can put it into practice. Great. That means that, I've got so much flexibility to help patients. Yes, I can't prescribe, but it's one where if you've got a teammate, that's not a problem. Yeah.
A teammate being like another doctor.
GP. Yeah.
So what would you say to, let's say I'm your client, I don't know, well, I am actually your client, but let's say for the podcast that I'm your client. I work really closely with my doctor and I'm going to listen to everything that they say. And we get these kind of clients too that come to you and you feel like you have this battle with the doctor, or you feel like it's that little bit of a push, like let's say in the sense of PCOS. How do you feel like you would approach that with a client, and how do you feel like you can kind of support that language and that dialogue to someone there?
Yeah. So one is get clued up on the condition.
Yeah.
So that you can go in there with a little bit of information and the GP can know that, okay, you've done some research. Yeah. They don't need to waste time explaining the condition to you. Yeah. So that's good, because generally in our medical system, you don't have much time with your doctor. And then look at it from the point of view that they're going to be a little regulated in their ability to test for things. They're going to need to hear certain criteria being met. So it's like almost a different language that they're looking for or are wanting to hear. So it's like outline your symptoms really clearly would be the first. So do your research. From that, you can outline your symptoms. So you can kind of, let's say, like you're saying with PCOS, I've got irregular periods. Or I don't have a period. Have you been using the pill or not using the pill? Have you got any family history, especially of unrelated, or we know they're related, but of diabetes or any blood sugar irregularities? Have you all of a sudden started gaining weight? And then you can outline this. So it's I even tell patients to walk in there with a list, because you might get in there a bit stage fright and just like, oh crap, I forgot. And then the doctor has to do the investigation with you and you might forget some symptoms.
Yeah.
We've all had that, walked out and remembered what we meant to say.
And those symptoms are important, because that's the reason that they will be able to test certain things. So for example, with PCOS, you can't test insulin if you're not having, irregular periods, or if you don't show for glucose intolerance or anything like that. So having all of those symptoms is really important to share that.
Yeah, exactly. And then they're hearing the right words. They go, okay, cool. Well, I need to investigate fasting insulin. I need to go and have a look at androgens or testosterone. They're probably going to do a female hormone profile and see if there's an unrelated condition to PCOS, why your periods are missing or why they're irregular. And don't forget kind of like skin changes, hair changes, things like that with PCOS. So you've got that. And then also realize, probably the last thing that I'd mention is that they're going to have a standard of care educated into their library of options to give the patient. And they're meant to say it to you. Yeah. You might not agree. You might not want to take metformin or you're really anti-medication. Don't feel that they're pushing it on you. They're just offering it to you.
So that's a meant to say that they have to sort of say that.
Almost.
Yeah, right.
That's right. So, and if they don't, they're not living up to their obligation of a GP outlining their options. Yeah. So if we list those, it'd be, the diabetic medication, metformin, or it might be an anti-androgen medication, or it might be lifestyle interventions. Yeah. But they have to tell you the meds.
Yeah, that's a really good point to make, because I think that's another element to feeling not heard is that clients will say, they just push medication on me and they didn't listen to the fact that I had X, Y, and Z. And it's kind of like the template and the way in which they have to work too. So it's interesting to kind of know that and to feel that way. Can you, while we're on that topic, in terms of like what to say to your doctor and how to sort of make sure that you're clear about that, can we speak on a few of those tests? So in terms of the number one question I think that I get, and that's because we specialize in hormonal health, is my doctor didn't want to do fasting insulin, or my doctor was against doing fasting insulin. Can you elaborate on that and explain that as to why?
Yeah, so there's a couple of reasons why that scenario may happen. One is the doctor's not educated in what fasting insulin means. Yeah, they'll know the hormone, but they'll have a library of knowledge missing on the interpretation of the test. Yeah. So that may be meaning that, okay, I might need to find a different GP that's got a better body knowledge in this particular condition. The other one would be the way you've kind of gone in there and gone, I want fasting insulin tested. Yeah. Now that usually lands on a GP as quite rude. Yeah. And that's just not how they prescribe Medicare tests. They need to almost decide of themselves, but also they have to kind of justify the cost to Medicare.
Yeah.
So that's why when I was explaining before is go through your symptoms. So if you list them off and let's say you've bring in that list I suggested, you've got all these symptoms. It's like, oh, this is likely PCOS.
Yeah.
And here's the criteria you need to meet via testing. So that would be elevated fasting insulin, elevated testosterone. And if they do an ultrasound, a pelvic one, they'd find that you've got cysts on the ovaries.
Yeah.
Yeah. You need 2 out of 3 to meet the criteria. So, they need it. They need to have the symptoms. You can't just go in there and bark a test at them.
And also, GPs don't work in the way that we use fasting insulin as a determinant of like how to give someone the appropriate calories and macros and carbohydrates. So they don't use that as a measure of like, we sort of use it as a tool.
Yeah.
But they don't. So that's also that change. Can you elaborate on that and how you would use something like fasting insulin in your practice?
Yeah. So in my practice, I wouldn't be using it as a diagnostic criteria. A lot of the times, we do get, let's say, a patient that is obese. We might find clinical insulin resistance. So that's an fasting insulin value over 20. Yeah. But then we'll have a lot of others that have got symptoms. So let's say we have a young woman with PCOS. They may not have a fasting insulin of 20, but it's 15. Yeah. Now you and I will go, well, that is insulin resistance. It's just mild according to diagnostic criteria. But it's certainly impacting on their body. Yeah. Now, if I take 10 points off that and get it to 5, now I've got a very insulin sensitive individual. They can respond to carbohydrates appropriately. They're probably not consuming the same amount they were before. So it's kind of like, as you were saying, it gives us clinicians indication of what's an appropriate carbohydrate level to produce a desired insulin level. Not discounting that we would encourage them to exercise and move, and that makes you more insulin resistant.
Yeah, absolutely.
Insulin sensitive, reduce stress, sleep more, etc. So we'd use it as that indicator. And let's say if we review fasting insulin. So if it's elevated, what is it doing? It means that you're essentially ignoring the hormone and becoming resistant to it in a cellular level. So your liver is not responding to the hormones. So it's like someone coming to knock on your door and it's a prank 15 times, right? So the 16th time, the person in that home is not going to open the door. They know it's that little punk trying to do the little prank, right? So that is essentially where you have to put more of a big knock to get that message across to the cell, or in this case, to get that glucose into the cell to where it's needed. Now that elevates the inflammatory processes of insulin, makes weight gain much more likely. It increases growth rates of certain tissues, and in susceptible women, elevates androgen levels in the ovaries. So, and that can happen at those under the diagnostic criteria. So let's say that insulin level of 15, that could be full-on PCOS for a woman. And it needs to be fixed.
What would you say as an ideal insulin level?
So I generally aim for 5.
Yeah.
But if I got a patient that's a 6, I'm pretty happy. Yeah. And it's the same that I aspire to. So when I'm testing my insulin, I'm either a 4 or a 5. Yeah.
And what about a 7 or an 8? And in that category, what would you suggest with that?
It depends. So we do have some patients that'll be a 7 or 8, but they're still displaying symptoms of insulin resistance. So let's say skin tags, acne,
irregular cycles,
and
they're essentially prone to further development of it.
Yeah, exactly. So if they kind of take their eye off the ball, so to speak, they'll fly up to a 20. Yeah. So those my colleagues and I would run a glucose tolerance test, which means you kind of swallow a horrible amount of glucose and then measure blood at hourly intervals, and we can pinpoint and find that they're insulin resistant still, even though they're fasting at 6 or 7.
And then can you elaborate on, in terms of like, let's say our insulin's 15, and as you said before, when you can just rapidly increase weight, So at 15, can you explain as to why it becomes that much harder to bring down your insulin unless you're very strict there, and how it can easily become a 20 or 25, 30 from there?
Yeah, so it's one where insulin resistance generally comes along with some weight gain. So, and it's a self-fulfilling cycle, so to speak. So the more weight you gain, the more hormonal changes elsewhere outside of insulin, inflammatory changes come from that fat.
Yeah.
That make the insulin resistance worse. So it's like, say, if I just hypothetically say an extra kilo of fat makes the percentage chance of a growth in your fasting insulin levels, go 2 or 1.5 times faster. So, and then it just keeps adding. Yeah. And then you mix in some stress in there, and maybe the person's gained enough weight to have sleep apnea. Now they're not breathing very well at night. Their sleep's terrible. Up it goes.
Yeah.
So a lot of people can relate to that in terms of going, it was slow, and then all of a sudden it was out of control. And
you see that all the time. And so many women that I speak to, it's like, I had PCOS, I was fine. And then in 3 to 4 months, and it would be like 20 kilos, put that on. And it's just that extreme kind of increase, which it's hard to sort of, if that's you or if you're experiencing that, you would think it's something to do with your diet or it's something to do with those just things that we generally look at. But that's why it's good to explore insulin. Talking about stress, can you elaborate also on cortisol while we're here as well? So that kind of impact, I feel like that's one that is difficult to test sometimes as well, in terms of some GPs will be happy to test it or not. It's also quite a trend to have, it's not a trend to have high cortisol, but it's sort of like the thing online that I feel like everyone presumes that they have at the moment because we're just stressed and overwhelmed.
Yeah.
So can you elaborate on that, why you would test it, and also low cortisol, high cortisol?
So cortisol being a long-term stress hormone, released from adrenal glands. So it's usually not in a general blood test, because you can just order a blood test and pick a time. So generally it's done in the morning, and we do a morning blood cortisol value. Now that test was not designed to test for stress levels per se. It was designed to test for 2 conditions, Addison or Cushing's disease. Yeah. So really high cortisol or really low cortisol, right? And it's a great test for that. There's further tests that diagnose you those conditions, but that's your indicative one. So most people go, I'm just going to test my cortisol and see if I'm, stressed. Right? And they'll get back a normal-ish value, or maybe mildly close to reference range. But see, that reference range was designed for those 2 diseases. Yeah. And it fluctuates day to day. So you might have a raised cortisol because it's Monday and you don't like your job and you're starting on Monday. The better test to do is what we call a cortisol awakening response, and it's a salivary hormone test. That's actually gold standard when we're talking about studies of stress hormones and the impact of that on health. That's what they do. So the scientists in biology are going to be testing salivary cortisol values. Now, the symptoms for really not low cortisol, but lower than what would be ideal, so you don't have a disease, but it's low, are very similar to high cortisol. This is where it gets really confusing. So you have a lot of people out in the public which go, oh man, I've got cortisol up to my eyeballs.
I'm so stressed. I must have high cortisol. Yeah.
And we can run this cortisol awakening response, and I was like, actually, your cortisol's low. Yeah. Are you exhausted? Oh yeah, I'm exhausted. Yeah. But someone can be exhausted with high cortisol. So it's one where the test can be really important to ascertain how to treat that patient. A lot of times in clinic, I don't need to do it because I know why they're stressed. So we can actually save the patient time on a lot of occasions and go, look, you're sleeping 3 hours per night. We probably should fix that.
You're stressed.
Yeah.
Whether it's low or high, it's not
Yeah,
good.
that's right.
Yeah.
Like whether they have, relational stress or they hate driving to work or whatever.
Yeah.
If they're only sleeping 3 hours, that's what you need to be targeting. Go, okay, we need to solve that problem. And you might actually like your job and your relationships might get better because you're less cranky and
all
things
of that.
like that. So
yeah. So in terms of because testing and how important it is. But then there is that other side to it where if someone goes and gets all these tests and they don't know how to sort of explain that, it almost becomes worse, right?
Yes.
In the case of cortisol. And that's what I see in practice as well. It's I'm really stressed, so I need to do less exercise. I need to just walk. And that there is a case for these kind of people, absolutely. But then the greatest stress that person is experiencing physiologically is the fact that they've got adipose tissue, so they're overweight. Let's say their insulin's elevated. They're not sleeping. Like that's kind of the issue there, but we'll kind of bring it back. So where would you, like, do you see that a lot in practice where you feel although people are kind of over-testing or overdoing it, or how do you navigate that ability to kind of individualize that for each person?
You want to look at it from a point of view are we going to get any clinical values? You're going to change my decision process as a clinician, because we don't want to not do the test if it's really going to help the patient, but we don't want to do the test just for the sake of it.
And to overwhelm them.
A lot of these tests aren't Medicare covered, so you don't want to overburden them financially. So you've got to discern as a clinician like that. Yeah. Me and my style of practice, I might say, why bother testing cortisol if I know why it's raised, if it is, and if it's not raised, I'll do these interventions and they may not work. Now I know you've probably got really low cortisol and you're exhausted. So you can sometimes do those practical tests. That does come with experience. It's something that you don't kind of learn in university.
What are those, would you say?
So let's say I've got someone, let's say they've figured out that, and this one's a recent patient. So they figured out that if they keep slamming down all these electrolytes with salt and magnesium in there, they always kind of feel better. I'm like, okay, why do you have to take so much?
Yeah.
What are you doing? Yeah. So let's have a look, go, okay, they're only sleeping 5 hours a night. They never put down their phone. They're always on. They have little downtime to kind of play and spend time just having conversations with their loved ones. They barely eat. They only eat like one meal because they don't have time for it. I'm like, that's why you have such a demand of these and why you feel so good. So let's address those problems and then bring down that electrolyte use, because essentially you won't need as much. Now, I could have done a cortisol test and it probably would have told me what I already knew, that they have had elevated cortisol levels. And what does that do? It increases your requirement for magnesium and sodium because you urinate it out really quickly.
Yeah, right. What else do you, so I know you use blood tests. I mean, there's a whole bunch of recent things that you're using with a lot of your clients. Can you explore those other tools that you're using with your clients at the moment and testing?
Yeah, so we run all sorts of different testing. So I love diving into the microbiome. So we've got what we call quantitative PCR testing. So how much good or bad or beneficial bacteria do you have in your gut? What functional markers are coming out of your stool that relate to how well you digest food, or if there's an inflammatory process there. So that's a stool test that we do quite often. We do big hormonal tests. So sometimes if we've got a bit of, question marks over like, how's this person metabolizing their hormones? We might do a urinary hormone, which are called Dutch testing. And because we can, in my practice, I can order any test I want out of a pathology lab. We do a lot more than what a GP would be allowed to do in Medicare. So we'll test things like leptin if we've got resistance to weight loss. We will test glucose tolerance tests with insulins added in there. We would do hormonal testing before someone actually has the disease process that would warrant it. So let's say thyroid function testing. We'll test T4 and T3. Medicare would never allow me to do that unless TSH was way up. Yeah. So that's our testing. In terms of my practice, we do all sorts of different other techniques. So let's say the fundamental requirement for the body to have oxygen, well, I can manipulate that a little bit. So in my practice, I have a hyperbaric chamber on offer as a service. and we, almost quadruple the amount of oxygen in someone's blood, and then permeate that through the tissues under pressure within this chamber and get them to breathe.
In what scenario and client are you giving that to?
So we would use that. Recently, we've got a patient in there that has got peripheral neuropathy, so they've got metabolic disease, poor circulation to extremities, and we're trying to regain some function back into nerves.
Yeah.
So nerves do not like poor circulation and low oxygen values. So we're doing that to see if we can get some reversal in numbness and tingling. We're utilizing it in chronic fatigue cases. They have poor oxygen utilization, so we're enhancing that. I've got a patient in there now who's just had surgery, and we're using it to enhance the healing of that scar, to reduce any scarring presentation. Multitude of things we do it for.
Okay. Yeah, great. I want to get into some trendy kind of, well, I don't know whether they're trendy or not trendy, or things that are talked about. So cortisol was one. There was a few I was thinking about for you specifically.
Yeah.
Can you elaborate on your thoughts on Ozempic?
Yeah.
And whether or not you think it is a good tool, a bad tool, the risks around it?
Yeah. So GLP-1 agonists, or Ozempic, Mounjaro, there's some other names, are essentially now used as weight loss tools. So they use these products to increase your body's ability to process sugar. Those are initial uses, but they work wonderfully well to essentially lower appetite and caloric intake. It's almost like tricking your brain. Yeah. Now, this is a mechanism that if someone's got obesity is actually upregulated. They just want to eat everything.
Yeah.
Right. And that insatiable hunger a lot of these patients will feel. So Ozempic can be really useful there in terms of getting the brain to go, I'm satisfied with this much food. Yeah. And I'm going to satisfy you longer. Yeah. So that could be very helpful for those individuals. Now, I'm against its use in terms of trying to lose the last 5 kilos to look ripped.
Yeah.
Probably not a good idea.
Why not a good idea then?
It's one where I'm all kind of like risks associated with benefits. So what are the risks with Ozempic? You are going to be more prone to reflux. You're going to be more prone to vomiting, because it essentially reduces the time, increases the time for food to empty out of the stomach.
Yeah.
Now, that person losing the last 5 kilos they wanted to do probably doesn't have a problem with their appetite compared to someone with obesity. So that's really not a risk I think you should take on. Constipation is another one. And, promoted out on the news is like this increased risk of thyroid cancer. Now, that risk is not a huge increase in risk because thyroid cancer is really rare. So don't get too scared about that. That's put out there in the media, because it's not a huge increase risk of it. It's just more than what it would be normally. But again, like, do you want to take on that slightly more risk if you don't have to? Probably not. The other thing too is essentially we've got some supply issues with it. So if you don't have it, then all the benefits go away. And if you haven't learned anything in the process, because that's the other thing.
Yeah.
So if one of my patients is on Ozempic, I will want to really educate them on going, how do you get in proper nutrition? Now that you're not obsessed about really calorie-rich foods and you actually have a bit more of a preference to healthy food, let's really drive that habit and make it stay. Yeah. Because they may decide to come off that drug, and if they haven't learned anything, then the rebound effects are pretty bad. People just gain all the weight back.
Yeah. And food is messaging. Like, if you are eating protein, your body will get used to doing that and you'll want to do that. But also, this is where it's that hard thing. If it's just for that last 5 kilos and you're really nauseous and sick, the last thing that someone wants to do is eat a whole bunch of chicken breast, right?
Yeah.
And they also can't eat. They've got no appetite. They're sick all the time. They can't eat sufficient calories, even be in a moderate calorie deficit. They're at this like aggressive calorie deficit. So you lose a whole bunch of weight, muscle mass, and then essentially metabolically coming off it, it's just you're in a far worse place. So
Yeah.
the longer you kind of spend on these drugs, the harder it is to come off it if you're in that place, would you say?
Yeah. One of the key factors is it may not be how long you're on the medication for, because the data there with diabetics is pretty good. They've been using it for decades. But it's more so, like I said, have you learnt any good habits? Yeah. And have you preserved your muscle tissue? Because that's the other problem. If they don't eat the protein and include the physical activity that increases or maintains their muscle mass, that reduction in calories, because you're just not hungry, can eat away at that muscle tissue.
Yeah.
And now you want to, well, I tell my patients, muscle tissue is expensive to keep on. It burns calories for you. Like you and I are burning calories from muscle tissue right now when we're doing anything. If you've got more of it, you have a higher metabolism. Yeah. So imagine if I've been on Ozempic, not done any of that, lost 3 kilos, 5 kilos of muscle mass. I now have a lower metabolism at rest.
Yeah.
And I've got to exercise a lot to make up for that.
And also it makes it, can you elaborate on why it makes it harder from when you started to coming off it to mitigate that hunger? And because you've been in such a calorie deficit for such a long time, it's almost harder when you come off as well.
Yeah, that's right. Like you might be, well, the stomach does kind of shrink. If everyone's done like a fast one time or been really ill and couldn't eat for, 4 or 5 days, they can kind of feel their stomach shrinks a little bit. So yeah, they can have that opposite problem that they can't eat enough to get that protein in to, put on some muscle tissue that they've lost during the therapy.
Yeah. Okay.
Yeah. So again, you just want to go into it informed on what you're fiddling with. Yeah. And be supported by the right practitioner to take full advantage of that medication.
Yeah, definitely. Yeah. The last one that I want to ask you about is gluten-free, which got a lot of hype maybe like 10 years ago. It was like much more of a hype, but I know that you don't eat any gluten yourself. No. And that's something that it kind of got hype because it was like, we're going to eradicate all these foods that have gluten in them and therefore I'm going to eat healthier because I'm just eradicating those. But why do you believe it's really important for most people be gluten-free?
So I still leave it up to my patients, but what I tell my patients when they ask me, why are you gluten-free if you don't have like an official intolerance or something like that? And it came from research coming out of Belgium, and it was essentially that all people, if they were eating gluten, triggered intestinal permeability. Yeah. So essentially your intestinal lining was more permeable than what it should via release of a little protein called zonulin. And you kind of fit it on a scale. So every bite I was eating, I was causing more hyperpermeability of my intestines. So me personally, I chose, well, why would I want to do that all the time? That has lots of downstream consequences. And bread is not an essential nutrient. So I don't really need to eat it to be healthy. Yeah. So I made that personal decision myself. It's also, I've got family members that are actually intolerant to gluten. So that's obviously very helpful. Yeah. And then I leave it up to the patient. So certainly if you naturally ferment your wheat and you get a wheat from an organic source and you do all this sort of stuff, that is going to be healthier than tip-top bread down the road or your sugar bun down from your bakery. But you're still eliciting some of that changes in the gut.
Yeah. And inflammatory processes.
Yeah.
Yeah. Okay, great. My last question for you is, and it's hard to pigeonhole it into one, but what would you, in about 10 or so years, what would you like to see change within health and integrative medicine?
Yeah, I'm quite passionate about essentially looking at medicine being a lot more collaborative, open, being able to amalgamate traditional medicine and evidence-based medicine. There's a lot of overlap between those two. And really look at patient-centered care instead of disease-centered care. Yeah. The moment it's like, wait until you're sick to go to the doctor.
Yeah.
Like, why would we do that? Why wouldn't we be preemptive with our health and get in there and prevent these diseases? Now, I know preventative medicine is boring to the public. It's kind of like, well, it may not happen for 10 years.
Yeah, definitely.
Totally get it. But the benefits of, let's say, avoiding diabetes is that you have more energy today. You have more clarity of mind today. You're able to recover from illnesses, just like the common cold, quicker. You're happier, less prone to depression. Yeah. You're sleeping better and more restored. Now, everyone would love all of those packaged up into a pill and given to them. And it's a lot sexier than avoiding diabetes. But I think the public just needs to be educated on, you can have both of those goals. You can prevent that disease that's boring and happen to your older family members, as well as get these performance improvements in terms of how your body feels today.
Yeah.
And then lastly, it would be, and I'd love for within my career to be able to achieve this, is improve the hospital setting. Like, everyone's been to the hospital and being fed that goop in front of them.
I know.
It's, a lot of the places artificially lit, beeps going off everywhere. You're poked and prodded the whole time. Really, they're not environments to heal. If we had better food put into those premises, natural light, better circadian rhythms for sleep, and watching all those, controlling the artificial light at nighttime, we'd have much better outcomes in terms of getting out of those places, getting back to loved ones.
Yeah, and longevity there. Yeah, definitely. Thank you so much. Where can we find you?
Go to my website, www.fugenhealth.com.au, or you can find me on Instagram, Facebook, LinkedIn. Just look up fugenhealth and you'll find me there.
Beautiful. Thanks so much, Adrian.
No worries. Thanks, Lily.
Thank you for tuning in to Below Her Surface. I'm Lily Cook, and this space is about digging deeper, beyond quick fixes, and into real, science-grounded conversations. If today's episode resonated with you, please like, subscribe, and share. Stay curious, stay grounded, and keep questioning what is below the surface.